Please kindly take your seats. Thank you.
Good morning, everyone. Hi, my name is Nolwazim Kwanazi, and I'm a professor of anthropology here at the University of Pretoria. I'd like my colleagues who are co-conveners at this conference to introduce themselves.
Hello, I'm Lenore Anderson. I'm from the University of the Witwatersrand and spend some of my time in Australia, hence the accent. I'm delighted to see you all here, and I'm really looking forward to the next 3 days. Thank you.
Good morning. I'm Andrea Whittaker. I'm a professor of anthropology at Monash University in Australia, hence the accent, and I'm very, very excited to be here. Thanks for coming.
Right now, I'd like to introduce the director of the Center for the Advancement of Scholarship. This is the center where the project Reimagining Reproduction, Making Babies, Making Kin and Citizens in Africa is based. This is one of the projects that is behind this conference. Professor James Ogude.
Thank you, Professor Mukonazi. Let me start by welcoming all of you. We have in our midst here our Deputy Vice Chancellor, whom I will introduce shortly, and she will do the appropriate welcome. Yeah. For now, I want to do two things. The first one is just to give you just a basic understanding of what we do at the Center for the Advancement of Scholarship. And then I will have the privilege of introducing our DVC, who is my line manager, but under whom the center falls. In other words, among how many portfolios the Center for the Advancement of Scholarship is one of them. I'm extremely excited, to talk to you this morning. This has been in the works for a while, and Professor Mukonazi was really one of our top-notch, researchers in medical anthropology, broadly speaking, and reproductive health. Has been talking to me about, this coming, convening of voices, as it were. So, as she said, my name is James Ogude, and I've been the director of this center for over the last 8 years, almost bowing out towards my retirement. Now, the Center for the Advancement of Scholarship, popularly known as CAS, as we call it, forms part of a global complex of institutes for advanced study, designed, as units to foster intellectual inquiry, enable excellent researchers in their knowledge production, and also promote innovation in science and scholarship. It was established in 2013. That is exactly when I moved over to the University of Pretoria from the University of Witwatersrand, where I'd been working for 21 years. And as it were, CARES was one of the first transdisciplinary platforms at the University of Pretoria outside the domain of university faculties, and it was meant for an exchange of ideas across disciplinary boundaries and across generation of scholars. In fact, that is one thing that we boast about, the fact that we work across disciplinary of scholars. We have very senior professors, we have mid-year professors, we also have a number of postdoctoral fellows that are attached to the range of projects that are located at our center. And of course, we also sponsor doctoral and master's students whenever we have funding, working closely with other related faculties. So CARS facilitates and inspires scholarly interaction, debate, and innovation among senior scholars, eminent visiting scholars, postgraduate students, and postdoctoral fellows. So if you want a place where you can engage and do some work, interact with other scholars, please, you are most welcome to visit us. You just need to let us know. And of course, if you have funding. Now, the center boasts of a fairly extensive and growing network of African and international collaborators. Through projects such as African Urbanities, the Food Systems Research Network for Africa, the African Observatory for Environmental Humanities. Indeed, our signature project within the center is grounded on environmental work, environmental studies. So that is one area that seeks to bring the range of multiple disciplinary projects within our center. And then, of course, we have the Reimagining Reproduction project that is led by Professor Mukonasi. So the center has ongoing research activities in 10 African countries, 7 countries from the rest of the globe, and partnership with over 23 collaborating institutions. The work conducted by the scholars based at the CARS seeks to address important social issues from a multidisciplinary perspective. I've mentioned our international networks. One of our major networks is what we call Observatory for Humanities. Observatory for Humanities, some of you might know, brings together a total of 8 observatories scattered across the globe. I'm excited that I was one of the founding members of that Observatory for Humanities. We have the European Observatory, we have the Australian Observatory, we have Asia Pacific Observatory, North American Observatory, South American Observatory, and what we call the Scampula, observatory that includes the Scandinavian countries, broadly speaking. And of course, the African Observatory is located, at our center. And, our mission is to encourage the place and role of the work that humanities can do in shifting, thinking and ideas, around, difficult issues that confront humanity at the moment, ranging from climate change, and we've always, led some of these things in different ways. One is thinking here of the work that humanities did in relation to the awareness that was created around, tobacco smoking and cancer in general. And precisely because we realized that some of these things are linked to human behavior. And because they are linked to human behavior and values, it takes humanity to shift our thinking on some of those areas. And finally, we are also linked to the Consortium for Humanities Centers and Institutes, another very major, global organization that brings together all centers of humanities. Currently, our president is based in the University of California, but it brings together many, humanities centers. And we are very proud that, in fact, we are one of the very few, in fact, if I can recall, it's just two of us, two institutes on the continent of Africa that is linked to this institute, or to this consortium that brings together, those of us in humanities. So, without saying much, because I want to leave the whole welcome to our DVC, I want to take this privilege to introduce our DVC academic, that is Professor Loretta Ferris, who is currently the Vice Principal Academic at the University of Pretoria. Prior to this, she was working as a law professor at our faculty here in UP, and she left briefly and rejoined UP again. That's how attractive we are. In February 2022. She was the Deputy Vice Chancellor, DVC Transformation, Student Affairs, and Social Responsiveness at the University of Cape Town, UCT, which is also one of our premier universities. She left that to come here. So she holds numerous leadership roles at UCT. She held numerous leadership roles at UCT, including the director of the Institute of Marine and Environmental Law, as well as a director of research, both roles which were located within the Faculty of Law. Professor Ferris has had 28 years of experience as an established scholar with international standing and commendable scholarly work, with 8 years of experience at a senior management level. She has experience in teaching and learning through her participation in multiple academic committees, including the UCT Teaching and Learning, Language and Social Responsiveness committees. From 2004 to 2009, Professor Ferris was Associate Professor of Law and Program Manager of the International Trade and Investment Law in Africa program at the University of Pretoria. Prior to that, she was involved in several roles at the Washington College of Law, American University, Washington, D.C., in the United States, as most of you may well know. In 1988, she obtained a BA degree in law at the University of Stellenbosch, as well as an LLB in 1990. In 1994, she completed her LLM at Georgetown University Law Center, again in the US, and she holds a doctoral degree in environmental law, an interdisciplinary field from the University of Stellenbosch. Professor Ferris is a member of the IUCN Academy for Environmental Law, where she has also served as a committee member in the Teaching and Training Committee, and was indeed requested to serve in a task team that was exploring innovation teaching methodologies for environmental law. She has served as an expert in the United Nations Environmental Program, that is UNEP, Montevideo process, focusing on the development of environmental law at a global level. She was one of 2 lead academics for the development of a global curriculum on compliance with and enforcement of multilateral environmental agreements commissioned by the World Conservation Union, IUCN, and UNEP. Professor Ferry serves on the board of BioWatch and chairs the board of Natural Justice, both civil society organizations with a strong focus on environmental justice. Just for the record, the Faculty of Law at the University of Pretoria is one of the leading faculties, not just here in South Africa, but with immense international recognition. So we're extremely privileged to have Professor Ferris joining us today to welcome you. And with that, I want to say, please have a wonderful stay at Future Africa. This is where the future belongs. Professor Ferris.
Good morning. On behalf of the University of Pretoria, it's indeed an honor for me to welcome everyone here this morning, whether you are from the university, whether you are from some of our colleague universities, or whether you are from universities outside of the country. Please feel very warmly welcome at this conference. I want to acknowledge the presence of Professor James Ogude, Director of the Center for the Advancement of Scholarship, as well as any other members of the senior management team who may be here. I have not seen anyone. I also want to acknowledge our keynote speakers. I know that some of them will be joining us online, but Dr. Ahmed Davids Akol, and here this morning, Professor Gerrits. And then, of course, the organizers of this wonderful conference, in particular, Professor Makwenazi, who has been working very hard and diligently together with her colleagues at Wits University, Prof. Anderson at Monash, Prof. Whitaker, and then also, of course, from the University of Amsterdam. I want to acknowledge everyone here, everyone's presence here this morning. Thank you for joining us. The theme of the conference, Reworlding Reproduction, Navigating Emerging Knowledge, Politics and Justice, is an opportunity to reimagine and reframe the way we think about reproduction, but also the ways in which we practice reproduction and reproductive health, as theory and practice remains deeply embedded in our colonial past, and therefore it is not untimely to reconsider and to continuously reconsider it from a decolonial lens. The conference also intentionally brings together voices from predominantly the Global South to rethink issues of sex and sexuality, of reproductive governance, of parenthood, etc. The list goes on. And this is a particular honor for me to open this conference because, as you heard, I'm a lawyer, but sometimes you end up dabbling in areas that is outside of your lane. And I recently did so, and I really must say had the honor to do so because I met a couple of women from the rural Northern Cape, which is where I'm from, and that's the part that Prof. Ogude did not mention, is that I'm a rural girl from the Northern Cape with Soikoi and San heritage. And so I met these women who told me their stories about being midwives. And when I went on sabbatical in 2021, I decided to do an archival project on these women or with these women. Not that I know anything about archival methodology because I'm a lawyer, I do desktop research. But I nevertheless found it so important and so compelling that I felt that I had to capture the knowledge of these women. And I was sort of looking in the program to see whether we're having conversation about indigenous knowledge around reproduction, around maternal care, about midwifery. And I think it's a conversation that must be had, and especially after I've started talking to these women, because these women in particular, and of course we have midwives across the country, but I ended up doing this project in the Northern Cape where I'm from, and because it was, in a way, it was a project that was close to my heart and close to my roots, and I wanted to tell the stories of my aunties and my grannies, and in a way telling the stories of these women was telling the story of my mother and her mother and her mother and her mother. And I came to understand through sitting in their living rooms and talking to them, I came to understand what a pivotal role they still play in the reproductive health of especially young, marginalized Black women. Women who do not have access to health care, many of them live about 100 kilometers or more from the closest healthcare center. And so without being in the hands of, if they were not in the hands of these midwives, many of them quite elderly. In fact, since 2021, 2 have now passed away. The latest, Omatusi, was 94 years old when she passed away. But when I was having my conversation with her in 2021, she was still practicing as a midwife. And so many of them would not have any birth assistance if it is not for the presence of these women. As a lawyer, I was interested in it because our legal framework does not provide for them anywhere. It erases them, it erases their knowledge, it erases the work that they do. In fact, it does more than that. It makes the work that they do unlawful, because the Health Act says that in order to work as a midwife, you need to be registered as a midwife, and that means you need to have formal qualifications. And so during the conversation, for example, we steered very clear and away from certain conversations, because I know that even mentioning, for example, death in birth could expose them legally. But yet, they literally save lives. Sometimes they realize, of course, that the work that they do is not lawful, and so they end up working between the margins. And one of the things that they always take care to do is to make sure that when a woman goes into birth, that they do call out an ambulance, of knowing that an ambulance is going to take 2, sometimes 3 hours to get there. But they do that nevertheless. In fact, some of them will get into a vehicle, and being a rural area in South Africa, it's often what we call a bakkie or a truck. So they would go get onto the back of a truck and stay with a woman on the way to the hospital, and many times assisting them to give birth at the back of a bakkie by the light of a cell phone. So these are the conditions under which they work. And so I feel strongly about the need for justice for the women involved in this form of reproductive and maternal care. And as part of doing some advocacy for these women, I've joined forces with a filmmaker, and we made a documentary called Vroedvrou, in Afrikaans Vroedvrou, in English translated to midwife. And that has led to a children's book, which will see the light soon around, because we want the younger generation to understand the role that these women are playing. And on Saturday evening, I was at a dinner and somebody came and said, I saw the film, can we please talk about how we can work together? And so I think it is important that we sometimes step out of our lane into disciplines that we know nothing about, but that we are driven by our passion. I also think that it's important that coming from different disciplines, whether it is law, political science, healthcare, health sciences, that we sit together and that we have conversations about those issues that are issues that people struggle with on a daily basis. And so I think it's very fitting that this conference, which is such a conference where different voices, different disciplines are coming together, is led by the Center for the Advancement of Scholarship, which you've heard from Prof. Gude, is very much the kind of center where we work across disciplines. I also think that it's fitting that it's taking place here at Future Africa, because Future Africa is what we call a transdisciplinary platform. In other words, of course, the difference between interdisciplinarity and transdisciplinarity is with transdisciplinarity, you intentionally partner with communities outside of the academy so that you bring in those knowledge systems that sits outside of the academy. So I hope that the spirit of Future Africa, of driving new ideas through a collective of different voices, will inspire your conference, and that out of this will bear fruit new ideas, but also importantly, bringing together different lenses to look at some of our practices from a critical perspective, and hopefully rethinking the way we are currently practicing reproduction. I want to finish off by making an apology. I would have loved, I looked at the conference and I would have loved to be part of this conference and to participate in some of the conversations, because this is an important conversation for me as well, as I've indicated. However, our business school is currently going through an accreditation process, and they've asked me to. Normally I join online, but they said this one is so important, you have to drive all the way to Joburg, which is where our business school is located. And so, Nolwazi, I'm really sorry that I can't be part of this conference beyond this, but I wish you all the best. I think this conference will be a wonderful success, and I look forward to whatever programs, projects emanates from here, because I strongly believe that when we meet like this and when we have the opportunity now again to sit around the table and to not sit behind our desks looking at each other through a camera lens, that it creates space and opportunity for us as from different perspectives, different disciplines, to come up with ideas that may change the world, that may change the lives of women in particular in the context of reproductive health. So all the best for this conference. Thank you.
And thank you very much to Professor Ferris. I'd now like to take the opportunity to introduce Dr. Tessa Moll, who was the chair of the steering committee of the conference.
Good morning. Thank you everyone for coming, far and wide and near to be here today. I'd like to thank, of course, the organizers, and as well my fellow colleagues on the steering committee. This is Richard Powis from Florida, University of Florida, Nicole Daniels from UCT and WITS, Mwenzla Blel from Newcastle University, Caitlin Gardner from King's and WITS, Zianda Majambozi from Stellenbosch, and Fiona Ross from UCT. So it feels so exciting to be here at this point, 18 months after we first started having conversations about this, and now looking over the program and kind of anticipating the kinds of conversations that we'll be having is just really thrilling. So about a year and a half ago, we began to have conversations that would lead to this gathering. And of course, the first order of business was to imagine the kinds of conversations and discussions that we wanted to foster in this space. We wanted to gather diverse scholarship from different disciplines that kind of pushed back and challenged the dominant narrative about reproduction in the global south, and particularly about Africa. And we wanted to challenge the conceptual apparatus as well of reproductive studies itself, and foster a place for rethinking our own approaches. And so why reworlding reproduction? For one, it's an acknowledgement of the world making and future making that is really at the heart of all reproductive endeavors, ranging from abortion to gestation to caring for the non-human world. And as we will discuss and share over the next few days, reproduction invokes aspirations and anxieties about the future, connections to ancestors, past, present, and future, kin relations of ongoing obligation, care, and indebtedness. And regardless of the configurations and the forms and the modes that it takes, reproduction is, of course, a social practice. The famous saying says it takes a village, but it also makes the village. So reproduction and the imaginations and the ideas that incite it, the care that it calls for, the material arrangements for making and sustaining life, the relations that make this all work or not, these all expand and retract social worlds. And so secondly, the notion of reworlding is also inspired by the scholarship of Sibelo Ndlovu-Ngetsheni. So in the work over the last 2 decades, he's been writing about the ways that knowledge and what he calls the cognitive empire and the form that it takes is really central to the maintenance of a Eurocentric model of the world that gets reproduced. And this is a world that was not only produced what Du Bois called the color line, but also an epistemic line, one that delineated who has the authority to, quote, theorize, think, and interpret the world. And so his call for epistemic freedom is one for embracing frictions and multiple ways of knowing the world beyond any universalizing or essentializing frameworks. So for our conversations over the next 3 days, we hope to embrace frictions and multiplicities to the many, many worlds of reproduction. And we anchor this conversation here in Southern Africa to situate these discussions, an acknowledgement of also how the epistemic line has historically been situated here. So we hope to incite reflections of our own practices of knowledge production. What are the worlds that we are reproducing as we work in research and activism in health and in policy? How is our work on reproduction, the concepts that we use, the methods we employ, our approach, practices, and ethics, how have they been shaped by a cognitive empire? And how can we take a step towards otherwise? So, because what I've always found very exciting about working in this field of reproduction is that it always kind of summons a potential and a possibility for an otherwise. While there is inertia and powerful mechanisms toward the maintenance of the status quo, reproduction invites creative possibilities, and it reminds us that social worlds are always emergent and in process. And so it allows for what Agamben calls tiny displacements of the world as it is. And it's also, as I've personally found in the last few years, deeply humbling. One imagines what that potential might look like, just as we imagined what these conversations in this conference would look like, and things turn out completely differently. So I look forward to our humbling conversations over the next few days, and thank you very much for joining us.
Talking about how things turn out differently, I think at this moment we're supposed to play a recording from Professor Dana Ain Davis, who unfortunately couldn't make it today. But as I stand here, I have no idea how this is going to happen. Oh, okay, I have a thumbs up.
Hello, I am so grateful and honored to have been invited to offer a few remarks for this incredible Reworlding Reproduction conference that's been convened by Lenore Madison, Nwazi Nkwanazi, Andrea Whitaker. And I want to also thank Charlotte Sahe and all of you for being a part of this conference. I am also wanting to, as the granddaughter of domestic workers, wanting to thank those people who set up and clean up in the spaces that you all will be in during the entirety of the conference. Please believe that I wish I were in community with you all in person, and I'm deeply saddened that a family emergency has prevented me from being with you. My very brief comments are rooted in some concerns about pervasive and unjust burdens faced by Black and brown bodies in particular across the globe. In early 2023, at the Reproductive Justice in a Post-COVID World Transnational Protest and Resistance Conference held at Cambridge University, I gave a talk called Transnationalizing Reproduction, where I engaged with questions about reproduction through the lens and logic of racism. In that talk, I opened with some very brief reports of racism in places that we, I think, at least among US-based anthropologists, don't often engage with when discussing racism and reproduction. For example, I talked about Rayshawn Ray's, who works with the Brookings Institute, how Rayshawn described in a report that Black individuals have faced discriminatory treatment in Ukraine and were refused entry at border points in favor of white Ukrainians. I described Senegalese street vendors in Madrid who had to organize into unions to combat relentless harassment from police in response to systemic racism. In Colombia, the internal displacement of millions of people, particularly those of Afro descent and indigenous women, were forced to leave their rural communities to escape violence, rendering them highly vulnerable among the internally displaced populations. In the talk, I think I also highlighted some of the troubling reproductive practices in Kenya, where Somali refugee women are coerced into cesarean sections. And I described really briefly in Senegal, where anti-abortion policies have had severe outcomes for people like Penda Sai, who was incarcerated after an emergency childbirth that ended up being viewed as an aborted childbirth. And finally, I talked about disparities in cross-border reproductive care driven by stringent regulations in highly regulated countries, particularly around repro travel, which has increased as people seek to bypass restrictions in their home countries. My whole point then was to underscore how the issue of racism is actually often too much embedded in a US-centric frame, and that we really must create ideological and theoretical links to global processes that exacerbate historical patterns of racism and discrimination. Building on those concerns, I later wrote an article entitled Uneven Reproduction, Gender, Race, Class, and Childbirth Outcomes, where I elaborated on the connections between global reproductive issues and the policing and control of Black and brown bodies. My intention has been to shift the persistent gaze toward the United States and its history as the dominant site and source of examining racism in reproductive health and medical encounters, something that even I must be held accountable for in my earlier work, where I explored the historical origins of what I call obstetric racism to better understand Black women's disparate reproductive outcomes. Basically, I'm asking us, as anthropologists and social scientists, What are the global legacies of racial science outside of Europe and the US? What are the legacies of imperial speculation that have resulted in outcomes linked to investment and disinvestment differentials in Black, brown, and white life? Through the framework of uneven reproduction, I think we might examine a range of historical legacies that result in Black and brown people's disparate reproductive outcomes in a transnational context. Deeper dives into the operations of colonial and capitalist power and economics will allow us to see that the dynamics of race, class, and gender that historically support white women's reproduction do so at the expense of Black women. The term uneven underscores that birth disparities are not merely a consequence of differential investments in health among racial groups at different times, but rather we must unpack how the investment in one group's reproduction are simultaneously connected to and in fact made possible by disinvestment in another group's reproduction. Uneven reproduction is shaped in the context of capital flows that threaten reproductive outcomes based on race, class, and gender. And examples of uneven reproduction that have wrought havoc on Black life include policies that have disrupted breastfeeding in places like the former Belgian Congo, programs in South Africa that segregated the living quarters of Blacks and whites, which orchestrated the distribution of Black labor to meet white needs and corralled the growing Black population. The practices of eugenics and sterilization in both Central Africa and the United States. Biospecimen cultivation, as was seen in the US case of Henrietta Lacks. Gynecological experimentation, and oppressive and extractive obstetric and gynecological practices among Black women in Brazil. The geographic breadth of the examples above illustrate the range of reproductive crises that have been constituted within transnational webs of racial capitalism. Again, uneven reproduction belongs to a kind of theoretical vernacular that directs our attention to patterns of colonial capital investment and disinvestment that can animate any adverse reproductive event or outcome. How? Because governing regimes make economic and ideological investments in practices, policies, and programs, generating a calculus that requires placing one group at greater advantage in comparison to another group. In other words, unevenness conjoins positive reproductive outcomes among white women to the negative reproductive outcomes among Black and brown women and people. I ask us to consider shifting the focus of hostile conditions away from being viewed as reproductive disparities toward the view of being disruptive to reproductive capacities that are connected to imperialism, colonialism, and enslavement. Here, the historical entanglements illuminate the causes of uneven reproduction in transnational context and illustrate the various registers at which uneven reproduction, embedded with capital flows, threatens reproductive outcomes based on race, class, and gender. Unevenness underscores exploitation, regulation, and resistance. From this vantage point, we see how disinvestment may be deployed through policy, practice, and programs that shape power over reproduction and reproductive possibilities. Then most importantly, I ask us to consider how those policies, practices, and programs across time and space might be connected to each other. What might we find if we trace the overlaps of surveillance over time? What ideological inheritances do we find in contemporary medical encounters? What economic exploitations have migrated from the past to the present? By exploring these avenues, we can shed light on the global dimensions of patterned exploitation. We can place imperial histories of investment and disinvestment in conversation with reproductive outcomes that show how policy, practice, and programs benefit some while harming others. The legacy of pattern investment into white life and racial capitalism has clearly had a profound effect on all kinds of people's reproduction. And I ask that we think collectively about both how we can theorize this situation and how we can organize collectively. Thank you so much and enjoy your conference.
Thank you. Professor Gouda has to leave us. I know he hasn't been feeling well, but has meetings later today. Thank you, Professor. I'm now pleased to introduce Professor Trudie Gerrits, who graciously agreed to give the keynote at the last minute. Thank you. Professor Gerrits is a medical anthropologist and emeritus associate professor in anthropology at the Department of Anthropology at the University of Amsterdam. Before working at the University of Amsterdam, she worked for 5 years at the Ministry of Health in Mozambique. Professor Gerrits is one of the pioneers of the field of infertility and assisted reproductive technologies in sub-Saharan Africa. She's well known for her work on these issues in Mozambique, in Ghana, and in South Africa. She's currently involved in a research project together with Professor Manderson and Professor Whitaker, which is on the emerging IVF industry in Southern Africa and all sorts of related mobilities or repro travel, as was mentioned earlier. Professor Gerrits' work actually extends and impacts beyond academic studies. She's been involved in several applied projects in Kenya, in Ghana, and in Indonesia. She's also been a member of various advisory commissions and is currently the chair of ShareNet Community of Practice on Infertility. Professor Gerrits, we're truly honored to have you speak today. Thank you.
Thank you for these kind words, Nolwazi. And let me first thank the organizers for inviting me to give this keynote at the very beginning of this conference, Reworlding Reproduction, and to talk about our research work on infertility and assisted reproductive technologies in sub-Saharan Africa. Of course, it was great to hear Dana, but of course we are all very disappointed that Dana Davis cannot be here today and give a full lecture. But I hope my talk, in all modesty, will also give you some sort of inspiration and food for thought. This year, it's exactly 30 years ago that I did my first study on infertility among the Makua in the north of Mozambique, a country where, Nolwazi already mentioned it, where I previously lived and worked for 5 years. I was a so-called cooperante at the Ministry of Health, and that was a decade after Mozambique's liberation from Portugal. And this was my master's thesis topic. But it was so decisive for the rest of my professional career. It was the start of my continuing involvement in the study of infertility and assisted reproductive technologies, both in the Netherlands and sub-Saharan Africa. And ultimately, this led to my involvement in the research project emerging assisted reproductive markets here in Southern Africa, which is one of the partners of the current conference. More about that later. Let me say a few more things about myself. As people who know me a bit, and there are some people in this room who know me a bit, in doing anthropological research, I've always been eager to address the so what question, trying to find ways to make our anthropological insights meaningful for audiences beyond the narrow ivory towers of anthropology and other social sciences. For sure, this interest has to do with my own personal background, including my first education in social work and my experiences in Mozambique. For me, doing critical medical anthropology, that is, taking the political economy of health and the effect of social inequality and injustice on people's health into consideration, this has never been a choice for me. It's the only possible option, I think. That's also the reason why I want to say a few words about the development of the SRHR agenda, as this has been and still is of huge importance for the field of research that this conference is about. As many of you will know, this year it's also exactly 30 years ago that the famous ICPD in Cairo took place, the International Conference on Population and Development, in conjunction with the World Conference on Human Rights in Vienna in 1993 and the Fourth World Conference on Women in Beijing in 1995, marked a major paradigm shift in the international field of reproductive health, from population policies and practices mainly geared to pushing women to use family planning devices in order to reduce population growth. The field turned to a new paradigm aiming to advance sexual and reproductive health and rights as human rights, promoting gender equity. I'm sure that for this audience, I do not need to further explain this paradigm change, its importance, but also the ways how it has been critiqued. And I think that will come back in this conference many a times. On the occasion of ICPD's 30 years anniversary, several reviews of the status of SRHR 30 years after the ICPD in Cairo have been made. And in this lecture, I'm not pretending to give an overview of these review results, but glancing through some of these reports and reading some critical reflections, a few points stand out. To summarize these, I think I'm in good company when I present here some of the observations of renowned feminist scholars such as Gita Sen and colleagues. Oops. In the last 3 decades, they are stating, major advances have been made in the field of SRHR in a number of directions with significant impacts on national laws and policy making, program development, and service delivery. However, they add, we have to recognize that in many areas, in-depth implementation, meaningful participation and community engagement, significant scale-up of investments, and effective accountability are still insufficient. As the editors of the journal Sexual and Reproductive Health Matters recently observed in their editorial 30 Years and Beyond, the story of SRHR over the last decades is definitely not linear, even where progress has been made, but one of continued struggles. I'm sure that all of you sitting in this room and also thinking of what Dana was mentioning to us, can easily imagine several areas in SRHR to which this applies. Thinking, for example, of the continued struggle for access to safe abortion, for respectful and non-violent maternity care, for improved infertility care, and, for example, comprehensive sex education. And also thinking of the ever-continuing need of increased access to sexual and reproductive care for people who are not heterosexual, cisgender women of reproductive age and able-bodied, but are living with HIV/AIDS or disabilities, are adolescents or elderly women, or belong to the LGBTQI community. As we all know, sexual and reproductive rights are increasingly under attack from various directions, right-wing politics, anti-gender movements, and religious actors are increasing their reach. Quoting the SRHM editors again, around half of the world's population will go to the polls this year. Moves to populist and right-wing governments, as we are currently also facing in the Netherlands, shame, will likely continue with a rise in anti-SRHR and anti-gender agendas. Conflict and humanitarian crisis will continue to have a devastating impact on populations in Gaza, Sudan and Ukraine, among others, and on reproductive health and rights as a consequence. Global challenges such as climate change and antimicrobial resistance will have direct impacts on sexual and reproductive health. In addition, the COVID-19 pandemic and the rise of the Black Lives Matter movement have underscored persistent inequities here, listening to Dana again, in people's well-being in general, but also specifically regarding their sexual and reproductive health. Reproductive injustice are further aggravated by economic instability and natural disasters. Thus, as Maya Unitan and colleague Pig have noted, there is a growing sense that sexual and reproductive health and rights have arrived to a certain extent, but justice definitely has not followed. Infertility is one of these neglected reproductive health issues leading to enormous inequalities and injustices. When I did my first research of infertility in Mozambique in 1994, this topic had hardly gotten any attention in the Global South, nor from anthropologists. Marcia Inhort's third book on infertility in Egypt was still to be published, nor from any other discipline, nor in reproductive health care or policies. In these contexts, and particularly in Africa, high fertility was considered problematic, not infertility. All attention was geared to family planning, intending to reduce the number of children, not the opposite. While by now we know that infertility and childlessness are huge problems, both in terms of numbers and in terms of the implications and consequences for the people involved. Let's first look at the numbers, even when I must admit that these numbers are not always fully accurate and not always up to date. And let's also look a bit at the causes of infertility to give you an idea of what it is about. Worldwide, 8 to 12% of couples experience some form of couples/individuals, that's one of the problems in the numbers in this field, experience some form of infertility during their reproductive life. Though in some areas in sub-Saharan Africa, the so-called infertility belt rate may go up to 32%. Also worldwide, about 3 to 5% of infertility cases is not preventable, but due to anatomical, genetic, or immunological factors which people are born with. The remainder of infertility cases, however, is sort of preventable and mainly resulting from all sorts of infections, many of which are reproductive health infections, resulting from STIs, unsafe abortions, poor obstetrical care, or improper IUD insertion. A multi-country study showed that in sub-Saharan Africa, up to 64% of infertility in women could be attributed to infections. This first map shows the spread of primary infertility over the globe. On this map, we already see some variety in prevalence between the different regions, partly reflecting sort of equal spread of the unpreventable cases. However, if we look at this map, it shows the prevalence of secondary infertility, which is, as you can see, much more unequally divided over the globe, underlying the impact of preventable causes of infertility. It's only since the 1990s that anthropologists, and Marcia Inor was one of the very first there, started studying the social construction of infertility in many places in the global south, examining people's lived experiences, the perceived causes of infertility, the social consequences, their help-seeking behavior, coping mechanisms, and so on. These studies, including my own in Mozambique, have shown the immense suffering, isolation, and stigmatization it often implies, and the impact on people's intimate relationships, their position in families and society, and their quest for conception, as Marcia called it, in a plural medical landscape, often in vain. Several studies in sub-Saharan Africa countries have shown sort of similarities in the impact of infertility, while, of course, ethnographic details vary per study setting, among other things, depending on the lineage system. In settings where a patrilineal kinship pattern prevails, social consequences for women, in particular physical and mental abuse by partners and in-laws, are often much more harsh than in settings where a matrilineal kinship system prevails. Interestingly, many of these early anthropological insights have lately been taken up by non-anthropologists. They have ended up in policy documents of international organizations like the WHO, aiming to raise awareness among policymakers and practitioners, advocating for interventions addressing infertility, or for publicly funded or low-cost IVF initiatives. However, in practice, this has, in most places, not really increased efforts to prevent or treat infertility, or to support or destigmatize women and men facing infertility and childlessness. With some exceptions, such as, for example, in South Africa and Uganda, infertility is rarely addressed in the public health system and has not gotten much attention from NGOs working in this field. Recently, however, we are seeing some changes in, for example, in some sub-Saharan African countries, patient organizations have been set up for people facing fertility problems, and especially in private healthcare, huge changes can be observed. As Bob Simpson and Kate Hampshire expressed in the book Assisted Reproductive Technologies in the Third Phase, IVF clinics are nowadays more and more spread around the world, increasingly also in the global south. However, as this map representing the regional distribution of IV clinics per capita shows, the distribution of IVF clinics in the global south is very unequal. Sub-Saharan Africa has clearly the lowest number of clinics per capita, while the previous maps showed the high prevalence of infertility in this region. And this inequality is even more visible when the regional distribution of IVF clinics is presented per estimated number of infertile women. The increasing global spread of IVF clinics has also led to an increase of anthropological studies on assisted reproductive technologies in the global south, although still very limited work has been done in sub-Saharan Africa. And in 2012, I got involved in one of the first studies on this topic in this region, together with Viola Herbst, who designed this study, and Ines de Farias. We studied the transfer and appropriation of assisted reproductive technologies to and in different sub-Saharan African regions. This was a multi-country and comparative ethnography, the three of us each focusing on one country. I was doing my research in Ghana, and we started from the idea that, as nicely formulated by Marcia Inhorn and Daphne Bierenbouw-Carmelli, technologies like IVF are socio-technical products which are shaped by human and non-human factors, including the technical features of the ARTs themselves, as well as by the economic, political, cultural, and moral environments in which they unfold. In Ghana, I observed an increasing demand for and offer of IVF, which resulted clearly from a number of societal characteristics and developments. First, having children is strongly desired, if not mandated by society. So people facing fertility problems are eager to get them resolved. Second, the healthcare system in Ghana is highly privatized, encouraged by structural adjustment policies introduced by the IMF and World Bank in the 1980s. And thirdly, Ghana has turned into a lower middle income country with increasing numbers of people belonging to middle and higher income class able to pay for IVF. In 2014, when I did the research, Ghana had around 14 IVF clinics, all of them private in various sizes, small and big. In general, the fertility specialists setting up these clinics were trained in Europe or the USA and had returned to Ghana to start their own clinics. However, they were confronted with a huge lack of embryologists, which complicated the running of their clinics enormously. Several of the clinics had to make use of so-called fly-in, fly-out embryologists coming from abroad to deliver their services in short periods per month. Moreover, at the moment I did my research, there was no legislation nor professional guidelines in place. The latter has changed by now. As a result, clinic directors then were fully free to set their own standards. This global IVF technology thus led to several local practices with implications for example, the number of embryos that were transferred, often more than the 1 or 2 embryos generally advised to be transferred in most Western countries. And it also affected the maximum age that women could be treated, the way the work of surrogates, egg and sperm donors was organized, and the duration of hospitalization, which in one clinic could be up to delivery, which in most cases was done by C-section. The clinic clients consisted of 3 groups: well-to-do Ghanaian citizens or people coming from neighboring countries, and Ghanaian people living in the diaspora, who for several reasons preferred to do the treatment back home, including, for example, the availability and affordability of matching donor material and of surrogates, and the possibility to do IVF above the age of 50. The way IVF is offered in Ghana definitely leads to stratified reproduction. Access to IVF is highly unequal. For most Ghanaian citizens, IVF is and was not affordable at all. Moreover, the mere availability of ARTs, of IVF, while it's not accessible for the majority of the population, makes the experience of living with infertility and childlessness even more difficult and harsh. The growing number of IVF private clinics in Ghana and the increase of the intermediary agency and the ART support industry, catering also for non-Ghanaians, led me, with Andrea and Christina Weiss, to refer to the country as a repro nub, a growing center of IVF clinics catering for a clientele, many coming from abroad, but not yet as big to deserve the label repro hub, as Marcia Inhorn has referred to huge centers of IVF clinics, such as in Dubai. In 2020, I got involved in the study of such a real repro nub, the IVF industry in the IVF industry in South Africa, in a collaborative project involving Wits University, Monash, and Amsterdam University, with Andrea Lenore, you already met her, Karen Hammerberg, who is not here, Tessa Moll, you've already seen her as well, and Cole Volks, who is also here. This is one of the projects, as you probably know, organizing the current conference, and most of the team members are indeed present here. And with this study, we aim to investigate the global networks and emerging markets for assisted reproduction in Southern Africa. And we had to focus upon the mobilities of patients to South Africa for assisted reproduction and mobility of ova donors, gametes, embryos, and medical staff across Africa, and also to and from Australia, the funder of the project. In this project, and we were building on a large number on earlier work, you see it on the slides, and some of these concepts that I'm not going to introduce now. Together, we interviewed, we currently are saying more than 100 informants. We lost track of the exact number. We really have to recalculate that. So including patients, nurses, donors, translators, clinical coordinators, gynecologists, clinic directors, and embryologists. And our key informants were coming from all over, from various sub-Saharan Africa countries, but mainly from South Africa. And we also did, while doing the interviews in those periods, we also did observations during visits to these clinics, both the private and the public clinics. And today I will focus mainly on the interviews with professionals. South Africa really is, along with Nigeria, the major repro hub in sub-Saharan Africa. It has circa 22 private clinics, 3 academic centers providing some publicly funded treatments, and a lot of agencies arranging gametes, donors, and surrogates for intended parents. In South Africa, there's a huge demand for ARTs and offer for IVF clinics, partially for the same reasons as I mentioned for Ghana. As in Ghana, however, only a very small part of South African populations who need it can afford to go to these clinics. Much of the services are provided for people coming from abroad. In South Africa, however, much more than in Ghana, we saw lots of clients coming for IVF from beyond Africa, from Europe, the US, and Australia. Unfortunately, we did not manage to get proper statistics on the number of foreign clients. South Africa is particularly attractive for intended parents from abroad for a number of reasons. The country has a well-known and sophisticated private medical industry. The use of ARTs, including the use of donor material and surrogacy, is well regulated. For example, surrogacy is only allowed when at least one of the intended parents is a South African citizen or resident. And South Africa is also an attractive tourist destination, so the IVF journey can be easily combined with tourism. There's a wide availability of egg donors of all colors, and this is particularly important because worldwide donated eggs are much scarcer than donated sperm. And finally, as Asian repro hubs like Thailand and India have recently been closed for transnational and commercial IVF, intended parents worldwide are seeking for new IVF destinations. While there is an enormous increase of IVF clinics in South Africa, and some expansion in the region as well in countries like Zimbabwe and Botswana, there is, as in Ghana and elsewhere in Africa, also a huge shortage of IVF specialists and embryologists, which results from limited training positions in public settings. And Moreover, embryologists, many of them trained in the public health sector, tend to disappear to the private sector. The scarcity of staff has led to a variety of mobile forms of work, such as flying in, flying out, FIFO, medical specialist and embryologist. This new mobile form of work can be seen as both increasing access to ART services, but definitely is also about expanding a commercial, interesting IVF market. We have also seen South African clinics extending services to nearby countries through setting up satellite clinics, for example in Namibia, to ensure not losing potential IVF clients from these countries to potential other competitive providers intending to set up IVF clinics in these countries. This model of satellite clinics used also in other places is very much based on financial considerations, yet we must mention, beyond doubt, some medical specialists also showed a genuine desire to increase access to ARTs. Both FIFO and this flying in, flying out, and the setup of satellite clinics often results in practice of batching. And batching describes the practice of using hormonal regimes to synchronize women's menstrual cycles, to allow for a cohort of women to undergo IVF treatment within the period when the infertility specialists and embryologists are available, as is nicely illustrated in the quote by a traveling embryologist. So he's saying, like, you collect all the patients who say they can be available in June 2022, for example, and then start putting them on treatment to prepare them for the IVF, and then they try to navigate them to fall the moment of aspiration that will fall on the same date. So that is how they plan their business. The implication of such batching regimes, both in terms of success rates, but also possible side effects and how women and men actually experience this kind of treatment regimes, still need to be further studied. Another new type of mobility that we came across was Andrea and Carl, who were doing lots of interviews with hypermobile couriers who are flying all over the globe with sperm, oocytes, and embryos to provide these materials at places where they are needed, and thus they are providing an essential linkage in this global IVF industry. The quote by an Australian courier, resulting from an interview that Carl and Andrea did, is a good example hereof. This was about an Australian courier flying from one place to another in Australia, but also flying out to Georgia to deliver and to pick up all those materials. So it's just one of the many examples, and they are still writing articles about it, so you can read more about that later on. Finally, we observed heated debates among the professionals we spoke with over the best means of lowering the cost of IVF and provide better access for poor infertile couples to ARTs across sub-Saharan Africa. The fertility specialists and embryologists conceptualized limited access to ART as a problem of high cost of treatment, lack of public funding for medical services and medication, poor policy awareness and prioritization of fertility problems, a shortage of ART clinics and well-trained expert staff, the need for patients to travel long distances, also within their own country, such as South Africa, and over-servicing within the largely privatized sector that is offering many expensive add-ons. very few, in our conversations, very few specialists commented on the profits of pharmaceutical companies or IVF clinics causing high treatment costs and thus also limiting access. And our interviewees commented on various interventions to lower the cost of ARTs, some of which are currently being explored in South Africa, such as the use of mild hormonal stimulation regimes, offering conscious sedation instead of much more expensive full anesthesia during the egg harvesting, or the use of a mobile laboratory with a low-tech incubator, which is much less expensive. And some professionals we spoke with emphasized the lack of data on these low-cost interventions to allow for the implementation. And one of them expressed concerns that low-cost IVF would suggest a sort of colonial mindset that inferior technologies were good enough for poor people in poor countries. But our findings also show that the ideas behind some of those low-cost initiatives were not always well understood. And the huge financial investments in their own private clinics might also influence the way they comment on some of these low-cost initiatives. Overall, all our interviews agreed that with few skilled embryologists on the continent, ART services, including low-cost IVF systems, could not really expand. Okay. Yeah. Okay. So, as anthropologists, we can do many things theoretically on these kind of insights. It gives us food for thought for ideas on processes of globalizations, on injustice, inequalities, on new forms, new practices in healthcare, and so on and so on. But for this lecture, I want to conclude with the concluding remark that Lenore and Andrea and me also made in an article that we recently wrote about. A reproductive justice approach to infertility starts from the basic tenet of people's rights and ability to access infertility treatments and services. Currently, intersecting systems of oppression, racism, sexism, poverty, and legacies of colonization and apartheid continue to position poor women living in poor countries as a target of contraceptive interventions, coercive contraception, and fertility reduction regimes. As a consequence, for most people in the region suffering infertility, being able to see a provider and access assisted reproduction treatment, if required, remains unattainable. Further, reproductive health measures to minimize preventable causes of infertility have been neglected. And I would want to add here also other interventions that might destigmatize infertility or support people with facing infertility and childlessness are also not at all implemented, not even thought of, hardly thought of. Few countries have fertility care and reproductive health policies, and most countries lack regulations overseeing the standards of care or implementation of ART. While such policies and regulations are in place in South Africa, most people in the country cannot access the high quality fertility care offered in private clinics. So that's where I want to end my lecture, and I think there is still a lot to do in this field, and I hope that the insights that our project and other research are providing us with, that these insights can inform the ongoing debates on these issues that I think have been overlooked too long. Thank you for listening.
Thank you very much, Trudie. This was perfect. We're now at 10:30. I'd like to say it's been an amazing morning, quite a jam-packed morning. We've had 3 introductions, 2 remarks, and 2 keynotes. That's quite something for 90 minutes. And so realizing that you'd all probably like a break and have some tea, please feel free to speak to Trudie during the break and during the rest of the days of the conference. But please join me in thanking her for this wonderful keynote and for stepping in at such short notice. And I believe Charlotte has something to say to everyone.